Okay, we'll make a start. So my name is Dr. Alexandra Rose. I'm the principal clinical psychologist on our brain injury service at the Royal Hospital for Neuro-disability.
And hi, I'm Dr. Sarah Crawford, and I'm a consultant clinical neuropsychologist here responsible for our brain injury service and our long-term care service.
And today we're going to be talking about assessing the untestable in severe brain injury and what clinical psychologists can do. Before we start, we just wanted to acknowledge some people who we work with quite closely and have contributed in various ways to a couple of the slides that we'll be showing you today. And that includes Sonia Suterik at Sal Colony and Professor Jonathan Evans and Dr. Brita Cullen, who were part of my PhD, as well as our RHN multidisciplinary team that we work with on a daily basis. So just to give an idea of what we'll be looking at, we'll briefly have a think about what the role of clinical psychology is in brain injury rehabilitation, what severe brain injury presentations look like. We'll discuss cognition and standardized testing and why we often hear the term untestable. We'll have a think about what we can do, think about some passive behaviors after brain injury and what this might cause for the team. And then we'll spend a little bit of time thinking about the formulation of mood and MDT working. So when we think about the role of clinical psychology in brain injury rehabilitation, a lot of it is looking at assessment, and that includes assessment of cognition, and that would be with standardized tests usually that have established norms and have very rigorous ways of being applied, and that's to establish cognitive changes related to the brain injury. We also assess behavior, and this is often through observation and through using recording forms like ABCs. And what we're interested in there is looking for what the triggers of the behavior are and trialing different interventions to try and reduce the behavior if it's challenging to manage. We'll also be involved in assessing mood, so screening for any mood difficulties and having clinical interviews with patients when they arrive, seeing how they're coping and adjusting after their brain injury. All of this leads us to creating a formulation. So in psychology, we're formulating, putting all that information together to get a good understanding of what the person's difficulties are and how they're presenting. But we also are working to have an MDT approach to the formulation, so how everybody understands the patient. And that leads us to testing hypotheses about their cognition, their behavior, their mood. And it'll also inform thinking around their mental capacity and their ability to make decisions. And those are decisions, specific assessments we've been doing. Some of the common ones we do at the Royal Hospital for Neurodisability would be capacity to consent to placement and capacity for discharge and onward care planning. And then, of course, all of this leads us into interventions. So looking at compensatory strategies, most commonly for severe brain injury, so trying to compensate for the function that has been lost. And this is based on the assessments that we've made. And then, of course, monitoring whether those are effective, how those are progressing, and if necessary, reformulating if things aren't working as we expected them to. So what does a psychologist do? So we assess cognition, as I said, emotions and behavior, and we do this via direct psychology sessions with our patients. Often we will do this in joint sessions if there's language issues present with our SLT colleagues, or we might be looking at things in function with our OT colleagues or seeing how they're doing in the gym with the physios. So we'll observe those sessions as well, and we're gathering information from ward staff and families, either in formalized forms like ABCs or in conversations and getting their views on the patient. We provide psychoeducation, so helping patients understand what's happened to them and manage their difficulties, and also providing that advice to family members to help them understand what's going on. We provide guidelines to help the team manage these difficulties as consistently and helpfully as possible, and listen to the feedback on those guidelines and adjust them as necessary. So when thinking about severe brain injury, we're thinking about the patients we see here quite frequently. So in the brain injury service, those are patients who are here for level 1, either assessment, if they're in a disorder of consciousness, or for goal-orientated rehab. So once they've emerged and they're progressing on a rehab pathway, we would be looking at their sort of ability to engage in goals. Or if they have emerged, but they still have significant communication and cognitive difficulties, we would be looking at disability management. So as I said, they have significant cognitive impairments, including disorders of consciousness. They might be nonverbal, they might be disorientated or lack new learning ability. They might have difficulties understanding or following instructions. They often present with cognitive communication disorder, and they have issues with executive functioning, so being perseverative or disinhibited. And this can make them an unreliable historian, and it can make them lead to them lacking capacity to make some, many, or even all decisions.
Okay, so bringing it back to first principles, why do we assess cognition at all? So we've said this is a key part of what we do, and this is why. If you think about all of us going about our day-to-day living, our cognitive functioning, i.e. our attention, our understanding of what's going on around us, our problem solving, all of these functions are underpinning everything we do. Now, that means that understanding our patients' cognitive strengths and weaknesses is obviously going to help us optimize their rehabilitation, make it as person-centered as possible, and help them think about how this impacts on their longer-term independence. So patients who understand their cognitive profile can make sense of why tasks that used to be easy now aren't as easy, but also importantly, what they can do to get around those difficulties or seek help from others when they need to. If we can help the families understand the cognitive profile, that helps them learn how to support the patient in daily life. And particularly trying to help families understand difficulties like executive difficulties, that's actually a cognitive issue, that it's due to the brain injury. It's not that the patient is being difficult or has had necessarily some kind of radical personality change. It's part of what's happened to them with the brain injury. And having a good understanding of patients' cognition obviously also helps the whole team, because otherwise there's a danger potentially either of overestimating patients' cognitive ability and then having unrealistic expectations of what they could do, or underestimating it, so not being ambitious enough about what our patients can achieve. So having those realistic expectations helps with our goal setting and helps the whole team support the patient. So when we think about cognitive functioning, and for any of you who are psychologists here, you'll know that we usually think about it in different domains. And we've illustrated some of those there. That's not meant to be an exhaustive list. But just to think about, obviously these functions are in many ways underpinned by different brain areas, although they all do also interact with each other. But when we do, a thorough neuropsychological assessment, we're considering functioning in these various different areas. And these are some of the tests that we use. Now, I'm obviously not going to talk through this because for most of you, I'm sure this would be gobbledygook, not necessary. But it's really to illustrate that we've got a range of different tools available and that we broadly categorize those tools according to those different areas of cognition. Now, most of the examples we've got on that list are tests that can only be administered by clinical psychologists. So we're the only registered professionals who can use them. But there are some examples on there of tests that can be used by other disciplines. So, for example, our occupational therapy colleagues may be using tests like the R-bands, for example. So it's not exclusive to psychology, although many of those examples are. But what do I mean by standardized tests? We've got a couple of little pictures at the bottom to show you these big kits that we tend to carry around with us and get out. Standardise, always the same. Okay, this is really important. It means that whenever we deliver one of these tests, we need to make sure we're following the instructions verbatim, that we're scoring according to strict instructions as how to do this, and that we're following the interpretation that's set out in the test. Now, when these tests are published, so the examples of the kits you see there, the test companies assess large groups of people who are representative of the wider population. Now, that's really important because what we get from this is that each of these tests contains something that Alex mentioned earlier, these norms, so data norms for the population. And what that means is that what we're doing then is we're comparing the scores that our patients achieve on our tests with the norms in the test kits, which gives us an indication of the quality of their performance. So we might be describing that in terms of a percentile, for example. So we might say they scored at the 50th percentile, bang on average, compared with other people of the same age on a particular test. We also might have it described as a standard score or as a descriptive label. So sometimes we've got interpretations in the kits along the lines of low average, or exceptionally low, or superior. You know, those are the kinds of words that are used in these kits. But it's not just about a score, okay? And that's something that we're really going to hopefully underline to you in this talk today, because none of those tests that we talked about earlier are pure tests. There is no such thing as a test that only examines executive functioning, for example. Other features, other abilities underpin performance. So, for example, the example we've given there is that poor performance on a memory test may not be because the patient has impaired memory. It could be that they were so distractible that they weren't paying attention in the first place, i.e. it was an intentional problem. It could be that they didn't understand the instructions. So it could be a language problem. So those are just a couple of examples, but we want to illustrate, I'm going to jump to the next slide and then come back to this one, the potential limitations of tests. So I'm hoping that you can all see that is an elephant. But what we're trying to illustrate here is if you look at these various blindfolded scientists standing around this elephant, each of them has only got one piece of information. And what that leads to is a misinterpretation. It's a bad formulation. So the guy at the back who is feeling the tail thinks that that's a rope. There's a woman towards the front of the elephant who's feeling a leg and thinks on the basis of that piece of information that it's a tree. And what you need, obviously, is for all of them to pull their findings together to actually make sense of what it is that's in front of them. And that's essentially what we're trying to do in our assessments. We're drawing not just on the test data that we see, the scores that we get on our tests, we're also thinking about what other information do we have. Particularly our observations, what do we see? You know, when we're administering our tests, it's not just about asking a question and recording an answer. We're also looking at, you know, is the patient paying attention? Is there noise outside the room and we can see that their eyes are wandering off to look out there and they're not paying attention to what we're asking them? What are the patients telling us? You know, when we do these sorts of assessments using standardized tests, we get a lot of rich information from patients telling us, usually spontaneously, what they found difficult and what they found easy. And that, again, adds to the richness. We're also often, we're looking out for things like intrusions or mistakes that wouldn't necessarily be captured in that standardized scoring that we were talking about earlier, but definitely feeds into our understanding of what we think we're seeing. Pre-morbid estimate is something that we're always trying to do in these assessments. And what that means is we need to get some kind of understanding of what would be expected for this person before they had their brain injury. Now, obviously, in an ideal world, we would have some kind of test data from before the brain injury, but in real life, obviously, this is very rarely the case. And so we're having to pool information to work that out. Why is it important? Well, if you think about it, if somebody's got a PhD in astrophysics, we are probably expecting a different pattern of performance before their brain injury from somebody who perhaps had a borderline learning disability and really struggled in school. So we can only make sense of the scores that we see now if we've got some understanding of what normal would look like for that person. So what has changed for them? And then you'll see we've talked about some of these other factors. Now, there's more than that. That's not meant to be an exhaustive list. But obviously, if we're assessing somebody in English and it's not their first language, that can impact on their performance and our interpretation of their scores. Cultural factors. You know, many of these tests that we had in the list earlier were either developed in the USA or in the UK. And that means that some of the questions may just have no real life relevance to people from very different cultures, or where societal expectations of things like education and what people learn might have been quite different. So we're always trying to get a sense from people, you know, about those factors so that we can take those into account. And then what we're doing with all of that information is a neuropsychological formulation. So Alex mentioned formulation earlier. So what we're doing is pulling everything together, not just the scores, but also what is the brain injury? Where is it? What caused it? Things like effort. You know, is the patient putting in full effort? And if not, why not? Factors such as fatigue. You know, does the patient start losing concentration because they're just too tired? Mood factors, so we will almost always, if we're doing a standardized assessment, we would be doing some level of mood screening to try and get a sense of, you know, is the patient depressed? Are they anxious? Are there other reasons that could be impacting their performance other than the brain injury? So what we're trying to get at is an overall description of what is going on for this person and why. Okay, so this is another slide really to illustrate that formulation. And I won't talk through all of this because I think you can see it, but really what we're trying to pull out here is that the neuropsychological testing, the actual test scores, is just one component of that. So we're also looking at what's the history. We're getting that from the records, but we're also getting it from the patients, because when patients can give us that information, obviously it's really helpful to hear it in their own words, but it also shows us what their current understanding is and whether there's any inaccuracies. And similarly, the collateral, that means where we can, if we've got a family member or a friend who can also contribute, obviously with the patient's consent, then again, we've got that extra data. And particularly, family information is really, really useful when things have changed that the patient themselves isn't necessarily fully aware of or has got a different understanding of, and the families are very good at giving examples of why that might have changed. So that's effectively where we're trying to end up with, pulling all of that information together. So I've just put that up again to remind you about this whole big list of standardized tests that we mentioned earlier, because the problem we've got with severe brain injury is all of those tests, going back to there, assume that the participants that we're testing have basic abilities intact. So to administer any of those tests, we're assuming that the person we're testing can understand a set of instructions, usually given verbally, sometimes in writing, but we're expecting that they will get the point of what it is that we're asking them to do. We're expecting that they're going to be able to hold the instructions in mind for long enough to follow them. So just because they understand them, if they've got very impaired working memory, they won't necessarily be able to hold them in mind. Those tests assume that our participants will be able to give their responses. So if it's verbal, that they'll be able to speak clearly and fluently, or if it's written, that they can actually read and write. And some of those tests involve manipulating objects, such as putting cards on different piles or turning blocks around to make designs. So there's an assumption that patients will be able to do that. But this is why we hear the term untestable with our patients. We can see all of these various things here that interfere with those basic abilities. Many of our patients have communication impairments. So our speech and language therapists do a lot of work at pinning those down, but they might have difficulties understanding, they might have difficulties with expressing their responses. It may be that they can formulate the words, but they've got severe dysarthria, so it might be difficult for us to understand what they're saying. Many of our patients have physical impairments, such as hemiplegias, so they can't necessarily write, they can't necessarily manipulate objects. Many of our patients have visual impairments, and those are a couple of examples. So we've seen people who are cortically blind, so obviously very little visual information being processed, or we might see people with visual field deficits, so they actually can't see part of the visual field around them. They might have awareness deficits, and we've put neglect there. So while that's usually visual neglect, those of you who will know about this will know that the issue is the lack of awareness, that the patients are just not processing things that are on the affected side. And anosognosia is where they're lacking awareness of other difficulties they've got. So we've seen people who are not aware, for example, that they are cortically blind. So they've got both the visual impairments and an awareness deficit. And then the cognitive load of testing. Many of our patients in our brain injury service get fatigued very, very easily. So whereas in an outpatient setting, we might be able to do 3 hours of testing with somebody and get through a whole battery of those standardized tests, with our patients, it might be that we've got 10 minutes and we achieve one thing, and then that's it. There's no point doing any more because we will just be underestimating their performance. So combinations of these difficulties, which is what we see in most of our patients, means that most of our standardized tests can't be administered at all. And this is where people use this word untestable. We hear it a lot from colleagues, outside of our organization, that these patients cannot be tested. Now, we're not going to go into detail on the particular point I'm about to make now, but we're not going to talk about making adjustments to standardized tests. We don't tend to do that, apart from very minor adjustments that we always report in a report. And the reason is what we were saying earlier: we cannot interpret the norms if we haven't delivered the tests in the exact standardized way that the test companies require us to do so. So we're only going to use those tests if we can do it properly. But what I want to do is reframe the problem. So all of those tests are only tools, okay? None of them are definitive in themselves. And if we can't administer a standardized test because of those basic abilities being impaired, we've actually already answered a key question. The patient's performance is impaired, right? It's not that they are untestable in entirety, it's that we already know that the level of impairment that we're seeing for them is such that, for a given test, it might be that the cutoff score is, say, the second percentile. Well, if we can't do the test with the patient, we know they're scoring below that, right? So we've actually got information. We see people assuming some kind of magic about numbers, almost as if there's some kind of definitive science if there is a number, as if this is the holy grail, this is what you need. But actually, what that leads to is people thinking that somehow a standardized assessment must be the best thing to do, when actually it isn't always. And what that can lead to is people wanting to do a test, even if it's not necessarily the most appropriate thing to do, and believing that informal approaches are not as useful or that functional assessments are somehow lesser. We would argue the opposite with this patient group. And we often get this question asked, which test should I use? Particularly when we're supervising our trainees and they're learning how to use these standardized tests. And again, there's this assumption that there must be a test, that is the right thing to do. And they come in and they say, which test should I use? And we say in return, that is the wrong question. Okay, your starting point is to think about the steps before that. So firstly, what do you already know about the patient's cognition? Because you don't need to test something you've already got the answer to. Then the next question is, what am I still trying to find out? Followed closely by, why is this important and for whom? Because obviously what we're trying to do is a person-centered approach. We only want to be testing things out to find out about cognition if it is useful to the patient in some way, whether that's by that psychoeducation for themselves that we said earlier, or whether it's more broadly about aiding that team and family understanding. But we really need to be clear in our minds about what we're trying to find out and why. And then we can think about, well, how am I going to explore this? The risks if we don't. Well, assuming that no assessment can be done at all, so we get that word untestable, and effectively then there's no formulation, there's nothing for anybody to go on. As we've already mentioned, there's a risk that we overestimate cognitive functioning or underestimate it. And often this is biased according to the patient's verbal language ability. So we find that when patients can talk, their cognitive abilities are often overestimated because it's assumed that if the language is intact, then everything else is, and that is often wrong. Equally, when patients are not verbal, there's more of a risk that their abilities are underestimated, that there hasn't been enough done to try and unpick everything else that's going on. We can get an accurate formulation, and what Alex is going to talk about in a minute is about this risk of assuming that the patients have low mood, they're not motivated, they're depressed, instead of a cognitive formulation. False assumptions is obviously a risk, and where it's mental capacity, obviously this is a really, really significant thing, because we all know that we should be presuming mental capacity for all of our patients unless we've got reason not to, but that if we do need to assess capacity, we've actually got to do all practicable steps to support people to make their own decisions wherever possible, and to appreciate that they may want to make decisions that we would consider to be unwise. So we've got to have that really good understanding of cognition to make sure we're doing those assessments properly, so that our patients are empowered to make their own decisions wherever possible and supported to understand the risks and the consequences of those decisions. And as we mentioned earlier, an important part about assessing cognition is to optimize rehabilitation. So if we haven't done it, then we're going to fail to optimize it. So what can we do? Oh, well, in most areas of neuropsychology, so when I was talking earlier about our outpatient assessments, where we might bash through 3 hours of tests in one go, what we're doing there is we're assuming that everything is going to be broadly normal and okay. And what we're looking for is, where are the deficits? So we're expecting lots of things to be okay, and then the things that are most difficult to be, just these areas of difficulty that will help the patient understand. Now, when we're talking about our group with severe brain injury, we're flipping that on its head. The Professor Graham Beaumont, who used to be the head of Department of Psychology here, framed this in terms of looking for islets of ability. So actually, you know, for our very impaired patients, it might look like there's nothing they can do in terms of demonstrating cognition. And what we're doing then is saying, but what can they do? And Alex has put this little picture here about, you know, establishing levels of failure. So for example, if a patient can choose between two items, well, you then might look at, you know, can they follow a two-stage command? Well, yes, they can in this instance. But look, what happens when they do a three-stage command is they can't do it. So it's looking at those levels of what they can and can't do. And I'm sure any OTs, SLTs, and indeed other members of the multidisciplinary team who are on this call will be saying, what about the MDT? Well, obviously, this is very much an MDT collaboration, and a lot of that work might be being done by the OT and the SLT. And potentially we're all, you know, working on similar things in slightly different ways or completely in collaboration in joint sessions, and very much looking at assessment in functional tasks. So what we're really doing then is thinking about how do we create a personalised approach to assessment, but very much, you know, from that clinical psychology perspective of a structured hypothesis testing approach. And one of the ways that we might do that is to think about counterbalancing simple questions. We'll give some examples of these in a bit. And again, you know, our colleagues may be using similar approaches. And always we're thinking about what's the formulation? What do I know about cognition? How do I know it? What does it mean for the person? And is it brain injury or other factors going on? So this is just some examples of those techniques to contrast closed questions, which is obviously yes, no questions, versus forced choice approaches. So you'll see the biographical, you're asking two different questions. One of those obviously is correct and the other is wrong. Okay, so that you get a yes response to one question and a no response to the other. Whereas the forced choice paradigm involves you holding up those two things, so it's that way or that way, and asking the patient to look at the one that shows their own name. Similarly with object recognition, you can do it one item at a time. You know, is this a pen? Is this a cup? Or you could hold up two objects and ask them to look at the pen. And then you can use that same type of methodology, whatever seems most useful for your patient, whatever they're most able to respond to, you can then expand it into those other domains of cognition. So we've given an example about memory there, where you can do it via yes, no. So you show them a set of items and then you show them some items they saw before and some they didn't. And you ask them for each one, did I show you this earlier? Yes or no? Or you can do the same thing where, again, you show them the set of objects, which is the example I gave, and then you hold up to and ask them to look at the one that they saw earlier. So that's how you would use that basic type of assessment. And what we're doing when we do this is whatever they're able to do, we're then thinking, okay, so if they can do that, what's the next most difficult thing? So then we're devising a new set of questions using a paradigm we know that they can actually make use of to see where do we hit that point of failure? Where does it start to become too difficult? Okay, so these are some examples of how one can assess these various functions without necessarily getting those standardized tests, which are in the middle column out, but thinking much more functionally. So cooking tasks, washing and dressing, you know, which our OT colleagues may be leading and we may potentially be doing jointly. All sorts of games. I mean, Connect 4 is the example put there. There is so much you can find out from Connect 4, you know, whether they can discriminate between the colours, whether they understand the rules, whether they can work out a strategy, whether they spot that you're about to win, or are they too fixated on what they're doing themselves, whether they can do the turn taking. You know, that's just one example. And I'm obviously not going to talk through all of these examples. Are there any in particular you wanted to
I think it's sort of, you know, thinking about what you're learning in each session, because we do these tasks in rehabilitation quite frequently, and just using that information and adding to your cognitive formulation. So if you're observing sessions or joining SLT sessions where we're reading paragraphs, thinking about cognitively, how are they processing that? How are they attending? What are they recalling? You know, if you're doing drawing and any worksheet type tasks, having a look at how they're coping with that. So really not discarding any information, using it to add to that formulation.
And I think that point you said there about the sessions is really important, because the beauty of an inpatient setting is that you can keep going back. So whatever you see in one session, and particularly when it's something you don't expect to see, you're then using that information to think about what's my plan for the next time. So being really, then you can put that structured approach in and really be clear on what your hypotheses are and how you're testing them. And I believe I'm handing over to you now.
You are. Before we move on to thinking a little bit about mood, I just want to say if there are any questions, you can pop them in the chat and we'll come back around to them at the end. So in our clinical practice, we have obviously mentioned that we frequently hear this term untestable when patients' cognition is severely impaired. And, you know, I suppose the question is the same assumption made for mood? Well, we find actually it isn't. We find that most people are instructed by clinical guidelines to use a mood screen, and because these are recommended by clinical guidelines that they pick them up, go do a mood screen, and that those would be valid. However, after a brain injury, we see a lot of passive behaviors. And that can range from lack of initiation, as well as reduced facial affect due to muscular changes, or just an inability to understand and follow instructions. And you get this perception of people saying he's not engaging with therapy, he's withdrawn. And some of the common assumptions could be that they're depressed, they're not motivated, they're bored, he doesn't want to. So these are things that when we think about rehabilitation, the next conversation tends to be about rehab potential and the ability to benefit from. And if somebody is depressed, there is a conversation that starts around, could medication solve the problem here? Now, our view is that a lot of the time when there is very severe brain damage, it's actually likely to be cognition. And there's very little evidence that there is medication that can help cognition improve, especially after very severe brain damage. So we see it as other possibilities could include that we need to rule out and have a formulation about is the cognitive impairment. Is it global? Is there attention and memory impairments? Do they have executive functioning difficulties that are resulting in them not initiating or perseverating? And that's leading to this perception of he can't do it. He won't do it. He looks sad. He must be depressed. If I was in hospital, then I would be depressed. And this all comes about with a person that you can picture that is not able to follow instructions, that is not able to independently initiate, that is not able to facially respond with appropriate interactions when they see their family members. Now, as part of my PhD that I completed, I had a look at how we assess mood when there's severe brain injury. I interviewed a large number of clinical psychologists and medical professionals and ran focus groups to get an understanding of sort of why is this an issue, and also what do we think we should be doing about it. And one of the things that was really useful to spell out that isn't often spelt out quite clearly is the significant overlap of symptoms of major depression and sequelae of a brain injury. So some of the things that happen after a brain injury look very much like they could be depression. So the graph that I created there shows you a list of symptoms of acquired brain injury, and the blue ones are the sort of ones that out of that are the only ones that are only associated with major depression. So all the other ones could also be associated with major depression. So if we think about tearfulness, weight loss, insomnia, changes in concentration and fatigue, things like that are all associated both with brain injury and major depression. So there's only two, which is feelings of worthlessness or excessive or inappropriate guilt, and recurrent thoughts of death or suicidal ideation, plan or attempt. And when we're thinking about patients with very severe cognitive impairment, it is incredibly difficult to access those two symptoms that would definitively tell us, actually, this is leaning more towards a mood difficulty than a cognitive impairment. So this is just a list of the most common mood screens that people are using when they're assessing patients after brain injury, and clinical guidelines suggest that we routinely screen after stroke, and it's sort of within the first 3 months, and then at 6 months, and then sort of every 3 months post that for a certain period of time. But one of the issues is that, yes, it's suggested in clinical guidelines, but they only make allowances for patients who have expressive communication difficulties. So they're saying if they can't talk, there are sort of pointing measures that you could use, or measures using pictures that they could use, and that gets around the language difficulties, but they're not considering cognitive impairment and receptive communication difficulties. So measures might not be valid. They may not understand the questions they're being asked. The patient might be unable to use the scale due to the sort of cognitive load of it. The concept of asking somebody about mood is quite abstract, and some of the tools that are designed are even more abstract. So if we're thinking about, you're asking a patient to consider mood, depression, and also you're asking them to then turn that into how dark is the circle that represents depression. That's quite abstract. That's quite challenging to do. As we've mentioned, they're unreliable historians, and for us to get a clear picture of a mood assessment, we're generally looking at symptoms over a 2-week period, or at least having a think about how this mood presentation has changed or is different from their baseline. And like I mentioned, there's a significant overlap in the symptoms, and it's really challenging to tease those out. So I asked there, I said maybe they're not valid. I can now definitively say they're not valid. We published this article in 2022, which is a systematic review of the depression measures that are suggested by clinical guidelines in the UK to use with patients after brain injury, and looking at whether they're valid in patients with severe cognitive and communication impairments. And what we found is that because patients with severe cognitive and receptive communication impairments were excluded from validation studies, there are no self-report measures that actually show adequate validity enough to recommend their use for this population. There was one small study that examined, with a lot of spelling mistakes there, examined 2 observer-rated measures, which was the Stroke Aphasia Depression Questionnaire and the Aphasia Depression Rating Scale. And we can tentatively recommend them, but that study was incredibly small. It only used 25 participants, so a lot more research is needed. So if we're thinking about when earlier trainees come in and they ask, what test should I use? If a trainee comes and asks what mood screen I should use, I am more inclined to say start with a clinical interview and have a think about how reliable they are and how much they're understanding about the questions you're asking. Because we don't want to rely on a score, then so a cutoff of 13 means they're depressed. Put that in a case note somewhere, and then that gets misinterpreted by other people who also understand what scores on a measure might mean. And we go down a pathway very rapidly that perhaps is more about cognition in our formulation, but is being misinterpreted as mood in another formulation. So as part of my PhD and the interviews and the focus groups that I completed, I compiled a formulation-based process to considering whether it is mood or cognition when working with severe brain injury. So it's a beautifully complex picture that I'm very proud of. My supervisor, John, insisted that we should make things more complex rather than trying to oversimplify things, because when things are complicated, we should consider their complexity. And this is quite complex. So the way that we sort of consider the formulation-based model is a lot of what Sarah's been talking about in terms of assessing cognition, but you're doing it sort of in stages of pre, peri, and post. So pre, you're doing all of that collateral collection, thinking about a context environment, thinking about the individual, their culture, their age, their values, the neurological profile, their history. But you're also thinking, why am I assessing? As a clinical psychologist, they've been referred. Do I think that this is likely to be mood? Do I think this is likely to become cognition? And what is the point of assessing? Is this a screen that's routine, or actually are they expecting an intervention? Because there are options for depression in terms of, if it is true depression, there is a medication option, but if it is cognition, we need to be making other suggestions rather than suggestions around mood. Your peri is then your actual assessments that you're doing, your hypothesis testing. You're making bespoke measures fit to the person. You're having that clinical interview. You're then taking that back to interdisciplinary team chats to have a think about what everybody else is learning and how that relates to what you're seeing. Post would be the intervention. So if you think it's mood, do we trial medication? Do we look at some behavior activation and see if that improves things? Or if we think it's cognition, do we think about scaffolding that cognitive impairment and seeing if that removes the barrier that these patients are displaying to engaging in rehab? On the outer side of it, you'll see a circular process of formulation. So you're formulating all the way throughout from the beginning, and in the background of you collecting your information, completing your assessments, and observing your interventions. And if necessary, you're reformulating. And this is an iterative process that's getting you closer and closer to a more definitive answer. The big red block on the side is the sort of immediate response needed. So obviously this is time consuming, and this is going to take some thought. If somebody is at risk of harm to themselves or is incredibly distressed, excuse me, we're not going to expect them to remain without support. We would be looking at immediate intervention, but that's also likely to be more on the side of reducing behavior that's at risk of harming the person, or getting our medical colleagues to have a look at, is there a medication that needs to be used to reduce any distress, which is a different formulation from somebody with a pervasive mood disorder. So like I said, formulation is really, I think, if you take the formulation, the sort of missing puzzle piece that needs to be used with this patient population. So then we come to working with the MDT. So when we're thinking about our role and how we add information to team meetings and what our assessments are doing, we're also thinking about how we're supporting the expectations that the team and family members have of the patient. So sometimes that can be overly optimistic. So it might be somebody who was in a disorder of consciousness, they've emerged and they've started talking, and the assumption is they're going to be totally fine, and therefore we should do absolutely everything with them, and then they can't do it, and they sort of don't know what's happened, and it's the cognition hasn't been considered sufficiently. Or they feel they're untestable, or they can't do anything, and they'd rather just move them onto disability management and discharge them because they've got no rehab potential. Or it moves into they're not doing anything, we think they're depressed, and then they want a bit of a magic wand to fix the person. So a lot of it will get referrals of, you know, they're not motivated to engage, or they're depressed and they can't participate in rehab. And like I said, we're going to then think about, why are we assessing? What's the role of cognition in this? Because most frequently we find it's actually their cognition is limiting them. There's also time pressure. So we work in level 1 rehab in our brain injury service. You know, more and more we're expected to turn patients around more rapidly, you know, keep contracts as short as possible. So we also are desperate for things to improve quickly and for us to be able to access patients as quickly as possible. So there is a perception that medications are a solution, that this will fix things rather rapidly. And that also is a bit of a fallacy. You know, antidepressants take 6 to 8 weeks to actually take effect. So even the use of medication isn't really going to solve the problem. And I think that's something that came up in my interviews with medical professionals in my PhD, is they feel pressure. They feel pressure to prescribe, to try everything in their arsenal to help the person, and to sort of consider it on the, you know, on the balance of probabilities. Would a trial of an antidepressant be harmful? Most likely not, so should we try it anyway? But like we said earlier, there is limited evidence for medications improving cognition, especially in severe damage. So if the formulation is cognition, that medication is really not going to help what the issue is, and we need to be thinking about how to support the better understanding of how cognition is limiting engagement and how that cognition needs to be scaffolded. And then the other thing that we always have discussions about is that it's the cognition is often the invisible damage. So, you know, if somebody's got hemiplegia and it's not responding and it's quite dense, we will quite rapidly be able to make prognosis about, actually that's likely to return very slowly, if at all. Whereas a cognition, people are sort of more reluctant to make prognoses about cognition, and it becomes an invisible damage. And then we see that somebody's young or pre-morbidly very intelligent, and you feel like there's so much potential if you could just get them to engage. And it feels almost like the onus is on the patient to be, you know, more engaged, more motivated, wanting to participate more. But actually it's their cognitive, that's their cognitive impairment, that's their cognitive disability. And that's what that's what we need to be supporting, is that disability. So some of the challenges that can happen when we're working with the MDT, and I think some of the challenges that can happen when MDT patients are dealing with some of, MDT colleagues are dealing with some of our patients, is that patients who are having labile emotions or a lot of tearfulness, this kind of gets in the way of getting tasks done. So, we have to do a lot of assessments. And if in their sessions, the person is crying and distressed and they can't engage in the task, they're quite desperate for that to be contained. And so that's where psychology needs to be stepping in. But I think if we're very honest, is that I think most psychologists I interviewed, and I know that two of us agree, even if we see somebody once or twice a week, they will still cry in the sessions. Crying is normal, crying is an adjustment response, and we share the frustration. So the other thing is that some people struggle to deal with emotions and feel that it's not their job to support emotional expression. But like we say, it's normal. It will occur frequently as patients participate in rehab, and also patients with this level of cognitive impairment will struggle more with sessions for multiple reasons. So it will remain challenging for them for quite a while in rehab. So expecting that to change rather rapidly is going to lead to a lot of frustration. There you go. Preempted myself. Changes may happen, but in small increments or not at all. So we also see a lot of patients where actually the severity of their impairments after their brain injury means that they're unlikely to make significant recovery, or if they do, it is going to take years and years. And even then, we always use the phrase that they're not going to be the person they were before they had their brain injury, because we can be confident with that. The damage has been that significant. The other thing that is quite challenging is that assumptions are strongly held and it can be quite difficult to change. And it's, for me, been very interesting doing a PhD on mood and listening to people talk about mood and their perceptions, and also just thinking about how the world perceives mental health and mood and depression and motivation and engagement and the sort of expectations of others, and that we come with our own biases and assumptions, and actually when we have that, it's quite difficult for the psychologist to change people's mind, even with a very robust formulation. It can be the need to keep repeating that and to keep saying the necessary things to get the formulation understood. And like I said, if we take anything from this, the goal of all of this is a shared formulation, using all that information, like Sarah said, that we can gather if we put the term untestable aside, about this person's cognition and what they can do and what they're able to engage with, and thinking about whether mood has a role to play or not, and sharing that information, sharing that formulation with the team. The formulation we have there is the sort of very popular John Evans formulation that we use quite a lot. And I think one of the things that's really useful to us at the Royal Hospital for Neuro-disability is that on the brain injury service, we do an MDT shared formulation, like a formal meeting, where we will sit as the psychologist, OT, and speech and language therapist treating that patient, and we will have a think about their level of cognition and at what level we're going to be assessing and intervening. So that might be if somebody is completely disorientated and there's no evidence of new learning, we're going to be stripping it all back and thinking about sort of errorless learning of orientation and sort of supporting them with all their cognitive needs. And I always say to my trainees that I would rather you errorlessly tell them the information until they say, yes, you told me that yesterday, at which point you can stop. And then the next level is they can probably engage in some testing, but we're not sure how much. And often our colleagues and I will discuss who wants to do a cognitive screen to just assess, can they actually engage in testing? Can they follow those instructions? Can they have enough attention to actually sit through the testing? And then deciding from there whether we stay at that level and have a look at more functional ability, or whether actually they're doing quite well cognitively and they could be having a full neuropsychological assessment, which is the third level, where obviously psychology would then see them for formal testing with the standardized tests. Before we finish up and see if there's any questions for us, we do have written about this in a couple of places. So we have a couple of chapters in Jess Fish, Shay Bitteridge, and Barbara Wilson's book, looking at rare conditions and diagnostic challenges in brain injury. The systematic review we published was in Clinical Rehabilitation, and then the results of the structured interviews around assessing mood and the focus groups are currently in press. Thank you very much for listening. We're just going to check with Anna about questions.
Yeah, thank you. So if you've got any questions, please do pop them in the Q&A tab. So we've got one, stop sharing, from Rebecca, and she says, I'm an OT working in brain injury rehabilitation. What are the most useful collaborative assessments between OT and neuropsychology?
Oh, I think that actually comes down to what you were just talking about, which is about having that sit down to share the information you know already and then work out kind of what your next step is. Because actually what you do either separately or together is dependent on that first stage of kind of what ballpark are we playing in here.
Absolutely. And I think, the sort of shadowing each other as well and working out what are the sort of things that give you the most information. We enjoy sort of kitchen tasks quite a lot here. We have lucky enough to have an OT kitchen that's quite quiet. And I'm always of the opinion that, if we're looking at somebody where we know that they're very cognitively impaired, so we can't use the standardized tests, we want to know what they can do. And that's also got a real life impact. So I'm thinking about, yes, I want to see how you can sequence everything to make a cup of tea, but I also want to see how are you thinking about risk in the situation and how aware are you socially of, what's going on around you and things like that. So I think those sort of functional tests, multiple errands tasks, but multiple errands tasks that are real as well, taking people outside hospital settings to make it sort of ecologically more valid. But yes, I think, like Sarah said, really what's been most useful for us is that a lot of these screens and tests that we all use look at the same things. It's just about deciding what's best for that person and who's going to lead on that intervention and then sort of joining up together when necessary.
And I think just to add to that, Alex has talked there about, kind of cognitive screening measures. I think just be really careful about a school, because the vast majority of those cognitive screening tests are not designed to be used with people with severe brain injury. They're there as dementia screens and the scores have no meaning. Very definitely be careful about domain scores. They scored this on the attention bit, but they scored this on the memory bit. So they've got an attention impairment, but not a memory impairment. How interesting. As we said earlier, none of these things are pure. It's combining all the information you've got to get at the formulation. So be thinking about it descriptively and then think about what do you want to test out next and how. Coming back to those questions of what am I doing? What do I know already? What do I still need to know? And how am I going to find this out? And having that shared conversation, I think.
Yeah.
Okay, thank you. And so the next question, Judith asked, do you include the fellows in the formulations?
So the formulation is shared in our weekly case review meeting. So that's where we feedback. So we work in a values-based goal orientated fashion. So we will set goals with the patient and we talk about those goals and our formulation then comes up in the case reviews. So yeah, it's sort of communicated in that way.
Okay. And Abigail asks, I just wondered what's the difference in this setting between a clinical psychologist and a neuropsychologist, if any?
Right. Okay. So the way that the registration works in the UK, so clinical psychologist is the only one that's actually a protected title. So clinical psychologists are registered with Health and Care Professions Council, like many of the therapy disciplines are. And that is the title you are entitled to use if you're registered. Now, neuropsychologist is not a protected title in the UK, but it is a specialty within clinical psychology. So when people have qualified as a clinical psychologist, there are a couple of different routes then to getting professional recognition as a neuropsychologist, which basically entails demonstrating that you've got the specialist knowledge required to be a neuropsychologist, that you've got the research skills, and that you've demonstrated competency in clinical practice. And then what you could do when you've achieved these things, mostly these days via some accredited university courses at Glasgow, Bristol, and Salomons is the other one. Then you can register on the British Psychological Society's Specialist Register of Clinical Neuropsychologists. So although it's not a protected title, there is that professional recognition. And it's only when you're on the register that technically you should then use the title neuropsychologist and should not use it before then. So as you can tell, because I describe myself as a neuropsychologist at the beginning, I'm on the specialist register, and you are many steps of the way.
Most of the way there.
To do a PhD along the way.
Thanks. Sophie asks, is the location of testing important, i.e. looking at a toothbrush in a bathroom?
Great
Ooh,
question.
great question. Yes.
Can be.
Depends on what level you're looking at, I suppose.
Yeah.
So if you're looking at sort of object recognition for use, maybe a bit better in context. But if you're just looking at somebody being able to accurately decide between an option of two objects, that's just you can do that in the sort of Bay Area or a quiet room. But yes,
that's
functional,
sorry.
functional, you would want it to be in context.
Yeah.
To sort of give them every chance of being able to demonstrate that they understand how to use that object.
I would say that thing that Alex just mentioned about quiet room is actually more important, because what we find when we're assessing at this level, these patients are so easily fatigued, so distractible, you know, any kind of disturbance can potentially interfere. So it's more about trying to make sure the environment is as uncluttered as possible in every sense, you know, sort of visual, auditory, everything else that's going on, so that you can hopefully capture the patient's attention if it's possible to do so.
Okay. Judith asked, do you have any particular ways in which you prefer the team to monitor any changes that medication or other interventions have on mood?
Right, that is going to depend on how you've assessed it in the first place. It's an excellent question, but it's usually going to be bespoke, because a lot of it has come from that journey of discovery along the way of why are you even thinking about mood in the first place. You know, usually there's a reason, usually there's a behavior that people want to change, whether that's right or wrong. So it might be that the patient is very tearful. It might be that the patient isn't engaging in sessions. You know, there's going to be something that's caught someone's attention. So then we'd be using that to think about, well, how do we assess it? And then as a team thinking about, given that we have agreed that there is a behavior that we want to change and we think it might be due to a mood problem, how are we going to know when it's changed? So it's not going to be a one-size-fits-all approach.
No, and coming back to that, the sort of formulation-based assessment of mood, that would be bespoke for each person that you're assessing, and that will be part of what comes out of that formulation is also how will we know whether this is working or not, or whether we need to reformulate because actually this isn't the approach that was correct.
But that's very much collaborative working in this case, you know, with our medical colleagues.
Okay. We've probably got time for a couple more questions. Sophie asked, are tests valid in any language? Can we translate a test and use it?
I think the answer to that is no. Isn't it? And there are some validations of some of these tests in other languages. As somebody who only speaks one language to my shame, I'm not going to be the person who deals with that.
There are some tests, and sort of the bigger tests, like the WAIS in intelligence scale measures, they have been validated in multiple countries, but I think you then need to actually go look for those validated norms, and usually they've changed some questions along the way. So I come from South Africa, and I know that Dr. Sharon Trutter has done a lot of work in culturally appropriate norms for some of the tests in South Africa, and that's involved changing the questions and things like that. So if you were to just use a translator, you wouldn't necessarily be having a valid test. It would still be sort of culturally insensitive.
Okay, thank you. I think our time's up. So if we haven't answered your question, do drop us an email at institute.rhn.org.uk, and we'll happily come back to you as soon as we can. This talk is being recorded, so it will be available on YouTube next week at the earliest. So if any of your colleagues or friends have missed it, do let them know. It will be available. And lastly, just thank you so much to Sarah and Alex. Thank you so much for presenting today. We've been delighted to have you, and we hope you can join us for one of our future online lectures or courses. Thank you.
Thank you.
Goodbye.